Good morning. Good morning, everyone. Take a couple of seconds for people to get seated.
Do you have slides?
So, first off, I just want to say thank you all for attending our panel discussion this morning. My name is Helen Tausch. I will be your moderator, and I'm the president and COO of Infinalytics. We do have an esteemed panel of experts here today, so the discussion should be lively and interactive. But before we begin, I would like to provide a framework for you for the provocative topic we'll be discussing this morning. As you know, our topic is personalized big data, predictive analytics, and business intelligence. Now, all three could be a panel discussion. All three topics could actually be a panel discussion in themselves. And I really felt that my homework was to, how should I say, string like a string of pearls together all these three topics. And to be honest with you, I didn't have an easy time. And I'm not sure if Monica Martinez Canales is here. I guess she's not here yet. But I have to give her kudos because she gave me the missing part of the puzzle that I needed in order to extrapolate how these three topics came together. And before I let you know what that third piece of the puzzle is, I did want to leave you in suspense for a couple of seconds here. But some of the commonalities that I found throughout the conference has been the question of knowing what you want to solve, having a goal in mind when you're addressing analytics and what exactly you want to deal with. I also heard collaboration in one of the panelists and also alignment. With that said, I truly think that the contributing factor that makes all these three topics together coagulate is that of prescriptive analytics. Because as you know, you can figure out what it is that you want to solve. You can apply predictive analytics to it. You can also apply business intelligence to it. But if you don't have an action plan, if you don't have prioritization plan, then all you have is big data. So what I'm suggesting is that with prescriptive analytics, where you have the synthesis, thank you, of data happening, you have priorities in place as to what it is you want to do and when. So we're looking at it real time, as opposed to what's going to happen 2 years from now, as opposed to what's going to happen 10 years from now. Now, might that change? Might your plans change? Absolutely. Is it malleable to change? Absolutely. But if you don't have a plan in place, then all we have is big data. So with that said, I would like to start with the panelists and have them introduce themselves. I'll start with Serena first. If you could tell us the company you work for, the institution, and your role in the company, and we'll go from there.
Okay, well, thank you for inviting me here. Seems like a great place to talk about big data. Everything's about big data these days. My name is Serena Nadaf. I'm at University of California, San Francisco, which our focus is healthcare. We're a healthcare-focused institution. I've been there since 2008 after being recruited from Vanderbilt, where I spent a good order of 12 years helping build things. Oh, talk louder. Okay, I will talk louder. Okay, we'll try to drown them. Okay, so hopefully you heard me in the background. I'm from UCSF, and I've been in the academic and healthcare research world for most of my career. After med school, I went to University of Texas, Southwestern, then to Vanderbilt, and I'm at my third position at UCSF.
I'm glad to be here. I don't think you'll have any problem hearing me. I'm naturally loud. I'm always tall and loud. UCSF is a great partner of ours, so I'm so happy to be here. I am the super CTO for GE Healthcare. I know nothing about healthcare, but we provide a lot of solutions to healthcare industry, and partners like UCSF, Vanderbilt, Stanford, the ones that you know in here, are all the ones that we work with, and it's a very scalable thing. And I have a great talent in here in the audience from our team as well in here. I'd like to share a video just to kick things off with you. And this is something that we just released, and I thought it would help how we're thinking about big data and what it means to us individually.
Wow, that's one way to get started. Do you guys feel fired up now?
That's not fair.
Not fair. Well, you know what? Actually, we're working together. So this is, I knew nothing about healthcare. I knew nothing about tumor board. I actually learned first time from UCSF, one of my first visits. They were explaining to me what it means. It's such a touching thing. I've been in different industries, but healthcare really touches us, the lives, my kids, my family. So bring it on.
Okay, we're going to bring it on. And on that note, I want to first thank you all for your great introduction and that great video there. But I'm actually curious to find out what big data in regard to healthcare means to the panel. And I'd like to start with Everett, since you brought it up, so you get to tackle it first.
Okay, so for us, it's about what we can do to the patients. It's all about the outcome. We gotta change it, and it can't be always about the task, what happened. We're talking about population health management, and the population starts with the individual. And the life cycle, the information that we're gathering about ourselves begins before we're born. Just if you think about it, you're pregnant, you're capturing the data, you actually have all the genetics information, and it goes through your life cycle. And all that information is available for us. Somewhere we haven't been able to capture that. That's the problem number one. And technical teams are trying to solve that. How do we make that data available? Because experts like yourself can actually turn it into insights. And they can use that valuable time that they have, the few minutes in front of us, will make a huge difference. The stroke patients need those minutes to save sometimes the brain function, the life of the individual. That is what big data means individually.
So I have to say that in academia, I would say in healthcare, one, we can't do this without partners like GE and others. In healthcare, we're looking at Can you hear me okay? In academic medicine and academic research, we are always looking, we're always at the bleeding edge, it seems like. We're trying to find the next big thing. So focusing on research, which is my background, all the data that we're collecting, the tsunami of data that's coming to all of us from all different angles, bringing it together is now the future of medicine. If you look back at any clinical trial that if a patient was on 40 years ago, for let's say lung cancer, the approach to treatment of that patient today, 40 years later, is still the same. The survival rate is exactly the same. And why is that? Is it because we don't have the right drugs? Possible. Is it because we don't have enough information about the disease? Very possible. But the only way we can tap into this in academic research and medicine and focus on this, what can we do to make a difference? And that is, right now, it is actually understanding the data a bit better, a bit more precise. And that's where the buzzword precision medicine, personalized medicine, all of us in academia, that's now the big thing, personalized medicine. Well, what does that mean? Well, it's about actually just understanding the data a bit more in how to apply our knowledge to data. You heard about the NIH big grant that came out last year, Big Data to Knowledge. We all applied for that. And because we are all trying to understand what is the knowledge network. And only through technology, right now, it is driving this. And so I sit here as a recipient of all the technology. I can, shameless plug, most of us in academia get together all the time. We have, starting tomorrow in San Diego, is the AACR, 50,000 plus scientists and researchers in healthcare come together and try to figure out what is the next big thing that's going to hit the bandwidth. And so from that meeting, a lot of things start. A lot of great ideas spark, and we have new ideas and new pathways. To bring that together, we can't do it alone, and that's why I think sessions like this, where we have a lot of companies here talking about their breakthroughs in big data and how they can help us apply it, is what the differences are. So I'll end it at that.
Thank you both. So the flip side to that question would be, what does predictive analytics and business intelligence mean for the healthcare industry?
Well, it's a good one. I'll take that. So if you look at it, there's the element of the research and finding out what that means, but then there's the element of how the doctors, the clinicians, your general practitioner is using that to care for you, and in the end, that institution somehow has to get paid. Somebody has to pay for it. So if you think about the local laws that we have, and there's something called meaningful use. So that means the outcome driven. So they actually have to show that whatever they have done really is helping the patient, and the care was given for the right reasons. So they weren't being, they were using the wrong drugs, or there was just not out of the habits giving this and that and so forth. So today we have capabilities that we provided to our general practitioners, tapping into the pool of all this data that we have, millions of patients. They can actually ask a specific question about their diabetic patients and the cure that they may, the care that they might be on, and their weights, this and that and so forth, all come into play. And then, based on the outcome, they can actually go back and get qualified for the business intelligence for the care teams. And when you take that to the hospital level, or the IDN level, it's even bigger deal. So they really want to make sure that they have some protocols that they're following, and that they're actually following the recipes that they have determined as the beneficial to the outcome, and managing the population in some cases. And look at Kaiser, in California, right? It's a big deal. So all of them are tying together is the way that we're hearing from our partners and our clients, and we as a patient.
Good introduction. So when I look at business intelligence and analytics, to feed off of what you just said, so in standard of care, business intelligence means a lot. It means analytics, so we can find the gaps in your practices, in your clinics, in your institution, because you can't do it. You have too much data. And so business intelligence tools that GE provides and your competition provides to most of us who have large academic focus teaching medical centers. Now, we do have a hospital, and so we need to understand where the shifts are happening. In research-focused institutions outside of a standalone hospital, business intelligence to us now means being able to extract our research findings and using the same business intelligence tools, now connecting the dots. Besides just financial data or analytics from specific clinics, now we want to extract next-gen sequencing data, the ones that are now being curated from CLIA facilities where they're now making its way to the clinical record, where now the physician can now look at not only the research data, which is now becoming the forefront of what we call personalized medicine. You can't do that without business intelligence as well. So, but it's still early in that space. And so we're still defining how can we apply this.
Thank you both. So with that said, understanding like the big picture, if we take it down a notch to the architecture of big data, the question then would be, what are the different architectures that we need to consider to take advantage of big data?
Well, you know, this is good. So I'm just going to take it because I'm a software guy, right? You know, the way that we used to deal with data and solutions is just not going to work. That's what the struggle is. If you look at it today, so you know, we had some homogeneous ways of approaching the solution that changed, and you know. Throughout the you can plug in anytime you want. And so if you think about it, data is coming from various places. Things that you wear, and or the MR that you're sitting in, that they're doing a brain scan, or the CT that you're sitting in, or you know, you're at home and actually you're gathering some data. And this requires a different type of architecture for the platform to be really almost real time. I mean, you use the word real time, but it's almost real time. It doesn't mean it'll never be real time unless you're in the care units. How you federate this data, what you do with this data, how you turn this into insight is the key, and that requires, we believe, next generation architecture, next generation way of doing dealing with the software platforms. And that's what we're seeing, that's what we're working on, and that's why I'm excited what we're doing in here and discussing in here. And I think this wave is going to happen, and this wave is going to also pull sort of what we have in the field today, because we can't, you know, throw away what we have in the field. That's always going to come, but we have to build it in a way that it actually augments, not replaces in some cases, but augments with the big data, big decision insights that we're providing. So, thank you.
What he said. So I have to say that, so big data, you know, big buzzword, but it's been around for a long time. Imaging data, that's big data. We'll go back to pathology data, flow cytometry data, research, clinical information that's been gathered from various instruments over the past 20 years. It's all really big data. Now it's the evolution of how you bring, like what you just said, how you're bringing this new architecture to, you can apply it better to all the different variables that exist. And so if you look at our approaches in academic research and academic medicine, is exactly trying to figure this space out. If you look at enterprise data warehousing and how people applied their money and their technologies at various institutions just to mine the data, now that's shifted, because now it has to be live almost. You can't wait, you know, a week to have your imaging data or let's say tumor measurements show up in your data warehouse in order for you to run queries and say, oh, give this patient a profile that I can approach for a specific clinical study, or did this patient fall into a swimming lane that is identified in this biomarker for a new drug, a targeted drug. And so how do you do that? And it is with advanced architectures, some things that we are all struggling with.
Thank you both. Okay, now this might take a little bit of thought, and that's fine. Take as much time as you like. But I was also curious about your vision or passion for big data to help address or solve.
All right. So my vision is that video, where and things like that I've seen, which is kind of futuristic. I know that we're trying to get there, and big, massive companies like GE, they have the bandwidth to actually make a difference, and there are a lot of small companies that are incrementally impacting this as well. And so my vision is that through knowledge, through a knowledge network, we bring enough information to the forefront where things that are being built and designed and we're trying to apply them can actually be used. I think we struggle on applying all this technology to good use. And so in another shameless plug, in the cancer space, where there's of course, one of the big diseases we're trying to solve. And for 40 years, the National Cancer Institute has been hitting every angle it can to improve patient outcomes, either through drug toxicities, phase 1 studies, through chemotherapy regimens, through combination of various things. And we have had very little luck in denting outcomes of serious disease over the past 40 years. I think one thing that has really significantly impacted this has been the Human Genome Project. And other similar types of things are starting now. But my vision is for all of this new information, 1,000 genomes, public curated data that's out there today, finding pathways to bring that to the clinic. And how do you do that? Through a vision of bringing institutions together. There's a national group called Cancer Informatics for Cancer Centers. 75 or so institutions that get together just to talk about this twice a year. And it is open to you all. I would love to see more people involved in this. The only way we can dent this is by more collaborations. So Google it, show up, and have more discussions.
Thank you.
I think, making the video real, I know because we're making it, so it is gonna happen, but it's an evolution. It's just not a set point in time, so it's gonna evolve. I think making that available to the world, to the masses is important, so that you can actually comfortably use it not just in the developed countries, but in the third world countries, in India, in Africa. But I'm much more pragmatic than that. I want to make sure that when I move to the Bay Area this summer, I don't have to worry about my kids' medical records. And I know that's the biggest pain that we're going to go through because it's all on paper. This is one of the reasons I'm still using the same doctor in Duke, even though I want to use UCSF, because they have everything there. And there are pragmatic things that we're envisioning doing it. But this is real, so we're trying it out in several large institutions because they've been sort of early on working with us. This is going to happen, and we're going to also see some of these capabilities really coming out in places like in India, where, believe it or not, they don't have the wired connections, but they have a great mobile infrastructure. My mobile phone works better there than in California. That's kind of scary. And we are able to actually provide an infrastructure there, a solution here. So we are on this journey, and it's a long journey, but we're touching the lives. And I know some of the genomic work that we're doing with the pharma companies saves lives. Right now it's touching an individual patient, another individual patients. Our job to really make it available to larger populations, to the masses. That's what we're very much.
Well, thank you both. I hope that all your dreams come true. And I think if I could add that's what's so wonderful about big data is that we don't have limitations. anything we think about, we can do. And, you know, it's like being a kid again. You know, we have dreams and we can test it out. We can put hypotheses out, test it, and see if it works. Get input, collaborate with each other. And if I could just say that that's also another element that's going to keep big data going, is the fact that there's no right or wrong answers. One of my, both of them are esteemed, colleagues stated, he said, you know, there's not only one answer. There's not only one person that can have all the answers. And, you know, and I think that's really true, and I think we're all aware of that. And that's why collaboration is so important. And, you know, and those that have had experience in certain areas that we don't, we openly communicate. And I think that's what's so wonderful about an arena like, or should I say, a place, a conference like this, is where we get to share our dreams, our ideas, and get feedback. So, with that said, brings me to my next question, which is about cloud. And I was just curious about some concerns you've heard about big data and cloud.
I'll start with it. I think we're going through the same kind of getting to be comfortable stage as the early days of email. I don't know how many of you remember when we first had internet connection, and then we had emails. And if you remember, in your company you had intranets and extranets, because you couldn't use your extranets internally for your emails and this and that and so forth, because we just didn't know, and it was a comfort aspect of it. But today, you know, we figured out a way, right? The technology has evolved, comfort has evolved. So if I were to look back 4 years ago when I started the journey in healthcare, I was, oh no, I can't do this. Today, it's less and less people are worrying, coming and asking me, oh, my data in the cloud, what does that mean? So it's just, we've always had cloud one way or another. We're just making a big buzz about it. But it's, you know, how you secure, it's not the data, it's just the environment that you're dealing with. Those are all the things that we keep hearing. And with some highly regulated environments in healthcare, so we have to worry about it, we have to really pay attention to it. Those are things that will make some of the innovative ideas to come to fruition faster. But there is a way to do it. You know, who would have thought that we would have a solution like this 4 years ago? Well, we were envisioning, but it took us the technology to kind of evolve it. Those are a few things that we're hearing it, but I think it's less of a worry, more of an educational, informational, and in some countries we've been deploying this very freely, very easily, because they know we are there to protect them, we're there to provide these services for them. But it will take a while. It will take a while for some.
So there is a big resistance in academia for putting things in the cloud. Okay, because of privacy issues. UCSF has been public. We've been hit many times with lawsuits because we have inadvertently lost data, and every institution is very, very hesitant to put things outside of their four walls. That is changing. I think because technology is advanced. Technology wasn't as advanced 10 years ago when we're having these problems. We're spinning our wheels, building these huge firewalls and redundancies and making sure that no one can get into the network and maybe attack the data or even steal the data. So, but that's changed. I think the future, a lot of the future is in the cloud. If it's not public clouds, local clouds, but the cloud technology is advancing in tremendously. And so I think we're all going to continue to count on the cloud being a big part of our future. How we apply information into the cloud, when it comes to big data, for example, right now, in any institution you go to, they're performing genomic research, clinical genomic research, doing next-gen sequencing. We're shipping disks around via FedEx because our pipelines to the cloud just doesn't make it feasible for us to ship 2 terabytes per patient up to some cloud servers and then do compute. Doesn't work. We all create our own local computing environments, and we have, high bandwidth potential pipelines within institutions tied to the instruments right into our cluster, so we can actually analyze the data much quicker and also a little more secure. But the first generation next-gen sequencing machine to the current generation next-gen sequencing machines, the amount of data coming out is an order of magnitude smaller. And that's going to continue to evolve. And as that evolves, and data becomes smaller and more fine-tuned, the cloud will become much, much more available and realistic for us.
Thank you both. And that brings up another question, since we're talking about challenges. What do you think the biggest hurdle to using personalized big data in healthcare is today? And I know you mentioned security, that seemed to be one, but do you want to, and you've expounded on that, but do you see any other concerns, any other hurdles that we need to be aware of?
I don't know if it is a concern, but it's the lack of what I would call some sort of standard. Been in various industries, been in process control industry, transportation industry, healthcare is my third pillar. This is the only industry that I have seen severely lacks a common way of exchanging the basic information. And yes, there is an HL7, and then the first time I heard about HL7, so if you've seen one HL7, you've seen one HL7. Really, that doesn't sound like a standard. And then DICOM is a little bit DICOM, but it's really bastardized if you think about it. They found a way to really ruin what was supposed to be good standards, because they chose to cut corners around it. So they can't really exchange it. So this notion of longitudinal data access to it, they figured it out in banks many years ago, right? You take your Visa card, you take your American Express, what have you, go anywhere in the world. Go to a bank, you get your money in a very secure way. And they also charge you for it, or then thankfully for that transaction. When you're happy, they're happy. They figured this thing out. And behind it, if you haven't looked at it, what it takes to really make that happen, there's some really good technology. And they can do that with your money. Why can't we do it without constructors? That's the problem. I don't know that it is a, it's just lack of collaboration. Lack of, I don't know, something. You're the bride. Tell me why.
So, very good point. So, you're hitting it on the nail, I think. Part of it is standards. Standards are like toothbrushes. Everyone has one. No one's going to share it. So they only want to use their own standard. It's the reality. There's so many standards out there that exist, and especially in the clinical world, we're striving and pushing really hard. Well, how do we standardize a subset of data? We have all these blinded research projects that we ship our data around, just trying to replicate. In my laboratory, I conduct an experiment, and I have my peer colleagues across the country in Boston do exactly the same experiment with the same instruments, with the same software. Their data is different. There's something beyond standards. You can use everything, but there's other areas that we're trying to understand. Well, what environmental variables impact the data that you're acquiring? If it's, one thing that works really well, if you go to Kaiser, that was here before, and you get a CBC count, and you go, when you're traveling and you hurt yourself, you go to a clinic and they do a blood draw, your numbers are going to be pretty much the same, generally. But beyond that, we're not even close. That's the problem.
Food for thought. Wow. Okay. So another question I have has to do with just looking ahead, like 5 years from now, where you see big data.
It's going to be bigger. For sure. if we think we're dealing with big data, we're really wrong. We just probably scratch the surface, so I don't know that we really know where it's going to go. We have to come to a realization that it's not about bringing all the data into one place. It's just a kind of not one. And having the access, would be nice, so it's we will see a lot more insight into the data, but you will also see some infrastructural, and we have a company that we're dealing with, Preditive. I think they're here. So you're going to see a lot more of those. It's going to happen. But in the same time, there are some other mechanics around it that the infrastructure will support that. But I don't think we really know where this big data is going to go. And we're going to see a lot of things around, how you search it, how do you make it meaningful to yourself, and we're just going to learn. Right, we just began, I believe.
Anything to add?
One thing I want to add to that is I think it's no longer going to be called big data. It's going to have another name. It'll be subsets of big data. So the name, it just new the era. The era will change how we look at this and how we actually announce this.
Very good. At this time, I would like to open the floor up to you, the audience, to ask our esteemed panel here any questions that you might have. And what I ask is that if you have a question, to please raise your hand. I believe there are mics, and if there isn't, then if you want, is there one? Okay.
We'll repeat the question.
We'll repeat the question.
Or you can come here. More fun. More fun, really. Okay. He is really loud.
So this is for you from G.
Oh, thank you.
And this is the third industry you said that you've been in.
Yeah.
So one of the things that I'd like to hear from your perspective is, how is the healthcare industry different in dealing with data as a user of data and as a client than the other industries? Because I think that there's a difference there, and I'm not sure that people really appreciate how different it is.
Thank you for that question. Yeah, there is a difference because I think on the healthcare side, it's all about the patient and the outcome and what we're doing, what we're caring for. So it's much more individualized, much more personalized, everything we're doing. On the other industries, whether it is aviation, transportation, control, whatever, we talk about smart grid. It's about the infrastructure, making sure things around us are running. So we have capabilities, we analyze the data, we make sure that our plant is running in a healthier way. We increase its life cycle so it doesn't shut down. But in our case, we want to make sure that the heart doesn't shut down, that the brain doesn't shut down, or the tumor that we're seeing is treated carefully. It's much more personalized. But comparing the industries from reduction of technology or reduction of newer things, there's some great things that we do in healthcare, but boy, if we could just get the fundamentals done, that those industries have done, we would have bounds of leaps over those industries. That's what we're suffering from. We're still dealing with, and I thought, when I was in process control industry, they were liars. They are by far the best in class in terms of technology. Smart devices, smart technologies, 10, 12 years ago. Then transportation, that was an eye-opener. We didn't have the clue, when the train was going to come in and how slow they were going. And now, I don't even know where my heart rate is and whether they have the right information about what they just diagnosed about. It worries me. So that's kind of the great scale.
Thanks for your question. Please, is there a microphone we could have?
Yeah. There is. It's right next to it somewhere. we'll repeat the question.
Go ahead.
Go ahead.
Go ahead.
All right, I'll try to speak louder. I'm pretty loud too. I'm not from the healthcare industry, but in my industry, or just my experience in general, we do have an issue which was kind of addressed or touched in the video, and I'm curious. So, thank you. So, I was just getting into my real question, which is, we have data scattered all over the place, just like the video. We have data at the primary physicians, central, or even cabinet. And we have data in various hospitals with insurance companies. And then how do we, what is the most effective way that we can combine the data and make some sense out of it? Because what I'm struggling with, we have scattered data. And then sometimes, like my query can't recognize the two fields are the same thing because there was a typo.
That's very true. Look, I'll start and I'll pass it on to my friend in here. It starts again with the lack of standard way of sharing. But the good news is, one really touching thing in this industry is everybody really wants to do the right thing for their patients. That is great. And they may not care for the same way for their plans, but they do care for their patients. And consortiums, they actually are more than willing to do that as long as it's the identified, anonymized, and we have millions of them. We made it available for anyone. I know that we've been part of it, and it is actually working that way for them to do clinical research or for them to do the analysis that they need to do. And then they can actually turn it into personal information. But we are lacking that infrastructure, which is the bottleneck in healthcare. I think some of these things will help. We're going to leave the data where they are. We're going to have access to it, just like you saw in the video. But I think it's the next step that we're taking. It'll take a while. It'll take a while.
Yeah, I believe that doesn't just apply to the healthcare industry.
No.
A lot of industries have the same problem. Yeah, thank you.
Just to add to that, I agree that a lot of breaking down the data silos is one thing. I think the whole notion of interoperability, which is tied to standards and agreed upon standards, regardless if it's healthcare data or any data, it doesn't have to be healthcare. Pure research data, it could be data tied to banks, whatever it may be. Data is data, and the systems, the computers that are crunching this data can't differentiate between human disease data and plant disease data. It doesn't know, it doesn't care. It's looking at address it based on how you define your standards and your interoperability methods.
Great question, thank you. There's a question there.
So when a provider gives care to a patient, provide care to a patient, so it shouldn't be any disincentive to access data, right? So but the vendors, cloud vendors, the business model is that we store the data for free and then we will pay when you access the data. So how do you reconcile that? You have to turn around the business model, right?
So what's happening today in healthcare, at least in most medical centers that I am involved with, the patients are getting access to their own records. If you look at any of the medical big EMRs out there, GEs, Epic, Cerner, Mises, there are patient portals now. It is the new era, giving the patients access to their own data when they want it, whenever they want it. Empowering the patients. They know their health and their disease much better than their own physician will until they get to that doctor. So empowering the patient is one big way, and that actually is changing a bit.
I agree, but I'm not sure we're answering.
So the question is more as I implement a solution, I have to use a vendor solutions or so fast failure. You mentioned your own good data history. So the business model we have is that okay, we will store your data for free, but to access the clinical data or the demographic data, you pay for that. But as a doctor, now I'm using a solution that runs on this platform. I shouldn't have this incentive. I shouldn't have to pay to access the data. So the business model has to change.
I don't know who was approaching you with that business model, but I haven't seen that business model. That's not how it is. This is actually about enabling people to be able to really provide this meaningful use example that I was giving. They're all freely addressing and going there in their own EMRs. They're asking, so here's what I'm doing. They actually compare to the big pool of data. Everybody has been contributing. You know, here's where I am, you know, here's the demographic of the patient that I have, and here's the care that I'm providing, and what should be the outcome? And then you ask that question, and then you meet your meaningful use aspects of it. It's all part of it.
And I agree, this is the application, I'm talking about the infrastructure. Like, you go to Amazon, you say, how you go to host my data? And say, yeah, we'll store it for free, and then that you pay for accessing.
You know, if you look at it from the enabling capabilities, whether it's your EMRs or your taxes and business and so forth, you're part of the infrastructure, you're part of the network. I'm not sure that it is going to change, or is it going to come at an increased cost, but it's going to lower your cost. If you ask me, that's where this is going. It's going to really lower your access to the information, to the data, and the questions that you'll be able to ask. But, you know, maybe I'm missing the other question.
Any other questions in the back?
We mentioned business models.
Yeah, loud, just a little louder. We can't hear you. It's green.
You mentioned business models, and one of my questions is, what are the pain points or the challenges that we can solve with big data that hospitals or physicians or insurance companies are willing to pay for?
Yeah.
As an analytics startup, I'm looking to sell something, and we can build solutions that can do patient similarity or comparative effectiveness. But what are the problems that need solving that people are willing to pay for a solution?
I'll give you one good example. I mean, everyone heard about 23andMe, right?
Yes.
Where you can actually spit in a tube and they'll give you, they'll provide you some really interesting information. It's a fee for service. Now, there's a lot of controversy around that. For example, many in the academic world are wondering, is it too early to market the human genome? Because we haven't answered the questions. Now we have the human genome. Now we understand what we don't know. And so you can, if you have all the data in front of you, and you are trying to see, well, how can this be what business model can be applied to, what area of this data can be useful, look at the 23andMe model. It's pretty successful, I think. Is it answering the healthcare question? Not really. It's actually just allowing you to understand your genome and kind of profiling you. Some people are saying, well, I can do a kind of a genome analysis of myself, and if you look at your profile, you'll like when I did my 23andMe, I was really shocked. I had no idea that 3% of my DNA is from Neanderthals. It's like, well, I didn't know it was that dumb. And I had my whole family genotyped, right? And so you look at that, and it puts you into these buckets. And so based on your heritage, your background, and maybe even some of your DNA, it targets, well, my son, maybe he'll be a good runner. I don't think so. I mean, we're too early to actually market it the proper way. So I think there's a lot of space to grow that market.
I'll give you another one. So we talk about population health management, but it starts with the individual. So if you look at your own insurance coverage, I'm willing to bet it has changed over the couple of years. If you're not smoking, you get a bonus. That's driven by the payers, right? The insurance companies. Because you are less likely to be a cardiac patient or whatever. But if you think about, we're trying to prevent you from becoming sick. But with sick as in hospitalized and so forth. And if you can find a way to really actually track it, whether the activities, and all that stuff, they might actually find it even more incentivized to provide you a better insurance coverage or lower cost insurance coverage, because I know I have this much body fat in my body. And when am I running or not, that's how I'm tracking it with my Fitbit or whatever the dashboard that I have. It's all out there. Now how do you synthesize that?
and make it available so they can turn this into, look at how they make money, where the pockets of cost is, go from there. There's a lot out there. There's a lot out there. Question?
Thank you for your question. We have time for one more, and then it's lunchtime for you guys. So, if you guys ask your question, please.
Okay. My name is Kurt. We are company provide home care IT service. We use the wearable devices to monitor patients' health status and collect data to that. This can solve chronic disease and intermittent disease problem. Our question is from our academic and industry, what kind of diseases that we can try to attack using big data, and where or how is there a website or somewhere I can get such information? Yeah.
Look, I don't know where you can get that information. It's all out there. And there's something called google.com. Just go there and search it. It's all out there, okay? And just to give you a couple of them, there's a lot of cancer care pathways. We're doing it. There's a lot of work being done there. You can do it. There's a lot of work being done on Alzheimer's. That's big data. And it's but I'm not sure how it touches to the home care that you seem to be in. But you're there for it.
So let me tell you, so the arena of telemedicine, which you're talking about, or healthcare devices, which is part of this telemedicine world, is a multi-billion-dollar surge right now. And so the devices, the digital health innovations. If you go to UCSF, for example, we have a digital health program specifically targeting devices for various diseases, heart disease, it could be immune tolerance disease, various diseases, depending on where you're focusing your technology on, what device you're developing. Big data doesn't seem to align up with that world too much because it's more digital data at this point. It's like the Fitbit world. You're gathering your data, and if you provide your Fitbit data to the cloud and analyze it against your same age, your same profile, you'll get some information that could actually help you as an individual. But if you're developing platforms or devices, that is a huge market, and I think the information that you need in those types of devices actually is small data. It's not big data.
Thank you.
Thank you for your questions, and will you please join me in thanking the panel? Thank you so much for your information. Thank you all for joining us. Enjoy watching the rest of the program.